that the kidneys can be affected, monitoring that baby's urinary output, knowing that the brain is affected. So looking out for what we call convulsions or seizures and managing it appropriately, checking to make sure that the baby's sugars are maintained. When I say maintained within normal. These are all basic things that as a country, with good education through these platforms, reaching out and educating our health personnel, we should be able to do. In terms of other, let's say, infrastructural things, there are so many others we can do for birth asphyxia. So it includes something we call selective head cooling. If you're able to have continuous EEG monitoring, that is, you are monitoring the baby's brain continually for seizures so that you can intervene as soon as it happens. We may not have all these things, but the basics, I think we have that we can help support when it comes to these asphyxiated babies. Thank you.
Thank you so much, Doc. Thank you so much for the feedback. I'd like to follow up with another question. When asphyxia happens, whose responsibility is it to break the news to the mother? How are we supposed to communicate this condition to the mother for her to understand and be on board with us in the treatment of the baby? Sometimes I see that healthcare providers have challenges in communicating to the parent exactly what is wrong with the child. But if you find yourself in a lesser facility, you may have the midwife or a nurse at post. You may have some officers, medical officers around, but they may not be present at birth. Whose responsibility does it become to provide information to the mother so that she is in tune with what is going on and understand the care that is required for this baby?
Thank you very much for the question. So really, I'd say that all the different levels of staff that come into contact with this mother have to try and educate the mother as to what's going on. So let's say, for example, this mother comes to deliver, and then we recognize that the baby's, heart rate is decreasing when we are monitoring the heart rate. That in itself is a period, as you are preparing this mother to let her understand we have to hasten this baby's delivery. If not, baby is currently under stress, potentially the baby may not be able to get enough oxygen to the brain. So therein, if that mother has to put in more effort, if that mother needs to take a decision about intervention as far as her delivery is concerned, because maybe we don't have enough time, we need to do an emergency cesarean section, all that is facilitating the mother's decision. Remember, we are in a country where sometimes people's cultural beliefs and other things feel that they have to deliver vaginally or else they are not quote unquote women. So sometimes putting in some of these truths right from the beginning when the mother is in the process of delivering baby, mommy, this is what is happening to your baby. Baby is not getting enough oxygen. Potentially when baby is born, this could affect the brain. So this is what we have to do. That is where the counseling should start. Certainly after the baby is delivered and the baby is floppy, therein is an emergency. So after showing baby to mom, this baby has to be quickly resuscitated. If you have the benefit of having a team, as part of the team is resuscitating the baby, someone should go to the mom and the family. In newborn care or in neonatology, counseling and giving feedback is extremely, extremely important. Remember, this mother has suffered for 9 months. This is the outcome that she's expecting. So all you have to do is tell them, okay, mommy, your baby is not crying. So they are resuscitating baby, giving baby oxygen, and then you keep them on board. If there's a husband, if there are other family members, you have to let them know this is what is happening. And then depending on the level of care that you can give, certainly you have to also start the referral cycle in place. If you are, resuscitating baby and this baby is not picking up, you're letting them know this baby will need more care. This baby currently is not getting enough oxygen. So as far as counseling is concerned, another thing I want to say is that counseling is not just done only once. Remember, this is a highly stressful event for the family. So once you give a bit of counseling at the beginning, the next person who comes into contact gives another bit of counseling. When the child gets to a referral center for further care, at the referral center as well, you will tell this mother about birth asphyxia. This is what is going on with the baby. This and this is what we have to do.
Thank you so much, Doctor. Um, from what you just said, it's clear that it's a multiple role. The healthcare provider has a role, the mother has a role, and then the father also has a role. I would like to find out from you what exactly should fathers be engaged in when a baby comes out autistic? What contributions are we expecting from the fathers to ensure that the treatment we give to the child is adequate and then is prompt?
Hello, can I be heard?
Yes, please.
Okay. So I love this question very much. We are always trying to tell our fathers. So right even during the pregnancy, we need our fathers so much. The father being attentive, going with mother for antenatal care, even being a reminder when it comes to her medication. Say she's hypertensive, for example, reminding her to take her antihypertensive, make sure that she's feeding well. All these are so important in helping to keep that pregnancy healthy. And then also there are some things we call delays, for example. So say, let's say wherever they stay or wherever they live is far from a health center. Certainly this mother will need the husband or the partner to be ready and available when she goes into labor, when it comes to even transportation to the site so that the child can receive adequate care during the delivery. In the unfortunate event that the mother delivers a baby who is asphyxiated, that husband or that partner needs to be available, even to decrease the stress levels on the mother, because hearing such news after 9 months of pregnancy is not easy. Because remember too that we mentioned that the intestines of these babies are affected, which means that one, we take time when it comes to feeding them. And then when we begin the feed too, we usually want to give breast milk, which is the best when it comes to the gut of the babies. So that mother in this her stressful condition at some point will be requiring breast milk of her. So that father has to be there, has to be, helpful. And then financially too, remember there will be drugs we may need, anticonvulsants if this baby is having seizures or convulsions. We may need antibiotics if there was infection, all of that. So the husbands and the partners and the fathers of these babies are extremely needed. So when it comes to purchasing the medications and helping all of these, giving adequate, should I say, tender loving care to the mothers, helping them to go through this very stressful time so that together they can help together with the healthcare workers manage the condition.
Thank you so much, Doc. Thank you so much for the feedback. Um, I'm very grateful for this answer because we live in a society where men have so much power when it comes to making some of these important decisions. And when it comes to payments of the newborn's treatment, mostly mothers rely so much on their partners for this support. Madam Millicent, please, if you're online, I have a question
Can
for
I say
you.
something?
Yes, please, you can.
Yes, I think when it comes to the fathers, one other thing that we hope that they come to is get to the point where hopefully we as health workers have educated them enough to help the mother to make the correct decision when it comes to the events of delivery and labor. Because one of the things that you find is that maybe an obstetrician will pick up an indication, maybe to do a cesarean section, and then mom says, I'm waiting for my husband to come. The husband comes and says, no, as the women in my family or this and that, they deliver like the Hebrew women, all sorts of things. And then there are lots of delays in actually even getting a baby who probably would have, had a better chance of surviving if the mom had agreed to have the cesarean section or the intervention done early enough. So we are hoping that in addition to everything that has been said, one of the things we want them to do is actually get to the point where they help the mothers to actually make the correct decisions when it comes to their babies and then themselves, and not to be the stumbling blocks to some of the operative interventions that are needed when it comes to, delivery of babies. Yeah, especially when it comes to where babies who have a clear indication for cesarean sections, and then mom says, I'm waiting for my husband. Husband comes in and says no. And then you can't do anything. You finally go in, or you go in too late, and then the baby comes out asphyxiated. So hopefully, yes, we get them on board to make the correct decision when it comes to these operative interventions that are so unpopular in our society. Thank you.
All right, Doc, thank you so much. We encourage participants to send in comments and questions to the chat so that their views are heard from time to time. Madam Obaya has a contribution. She says that I think fathers should join this training in subsequent times so they also get abreast with this happening. And I think this is in line with what Dr. Sally made. Yeah, it's very necessary. We need their support as well as any important stakeholder in the life of the newborn, the grandmothers and the grandfathers, because they also come in seeking for answers. Why is a newborn still in the hospital after the mother has delivered? There's nothing wrong with the woman. Why are you keeping her here? There's nothing wrong with the baby. In our family, it does happen, and we have these traditional ways of taking care of it. So the earlier we involve families to understand what the newborn is experiencing and the possible consequences it could have in the future, I think it goes a long way to help us all. Thank you so much, Doc. Madam Millicent, please, are you online? Hello?
Yes, Shina. Please, I'm around.
All right, so we want to look at it from the lower facility levels. Transferring a newborn from maybe a CHIPS compound, a health center to the district or the higher facility. What are some of the challenges you've come across as a midwife when you have an asphyxiated baby who needs referral to the next level?
Okay, thank you very much for the question. There are so many factors that midwives encounter when they are transferring babies to a higher facility. So, first of all, I would like to talk about inadequate logistics at the CHIPS compound and other clinics. Most midwives do not have the equipment to manage asphyxia cases and so need to transfer the baby. Sometimes there is inadequate knowledge to be even able to identify the asphyxia and refer. Secondly, issues with transportation, trying to reach the higher healthcare facility to seek for support. You know, in the villages, it may be that we have only one vehicle, and maybe by the time the asphyxia is noted, the driver is not around. It takes a long time for them to get to the driver to bring this baby to the higher facility. And this is a very big challenge to some of us at the hospital and the district level. Thank you.
Thank you so much, Madam Millicent. And one factor we could look at is the cost of ambulance services. I work in Kranza, and if you have a baby who needs tertiary care, it costs about 1,200 to 1,500 to transport a baby. So you can imagine the impact of this cost alone on the family and deciding whether we should go to the next level. And it becomes so painful when money is a determining factor of whether a child can get the needed treatment they need or not. Especially when you know you've hit, there is nothing you could do at this level. The next best thing you can do is to refer. But then the cost of transportation and then how easily you could have it to transfer this baby becomes a challenge. And I think as a nation, this is something we should take a very critical look at. That in the transfer of the newborn, can something be done? Dr. Boakye-Yaadom, please, can something be done? When the lower facility levels have hit, there is nothing they can do. The baby has to go on to the next level. Is there something that as a nation we could do to fast track the movement of this baby so that cost of transportation does not hinder the needed treatment?
Thank you, Sheena. I think that you have actually outlined what can be done. I know that in the Ashanti region and then in areas close to the Ashanti region, we have a neonatal platform. And of course, we know that birth asphyxia, as we said, is one of the topmost referrals to, I would say, not only the tertiary hospitals, but now we have, I would say, quite a number of pediatricians who are not in tertiary hospitals, but are also doing marvelous work at maybe secondary level, regional hospitals, and all of that, and transferring these babies from even, as you said, lower level healthcare places, even our middle level, I'll say, where even pediatricians are, to the tertiary hospital, like the teaching hospital where I am. It has been one of the topics that have generated a lot of passion, because sometimes we just find out that everything is ready, but then the ambulance is saying this is how much they will charge. And the parents, we just don't have the money. We can't pay this money. And then, I mean, the child is, should I say, want of a word, locked up in a place where they can't do what needs to be done to help such a baby who has suffered birth asphyxia to recover at the next level. So I would say that, yes, we all need to get on board. I know that we have had a couple of discussions with our ambulance, national ambulance team. And I would say the Ashanti region newborn team. So like newborn team is just all pediatricians, neonatologists, and then midwives. And then we brought the national ambulance team and personnel on it. And I would say that we really haven't been able to come to a compromise to really help make the ambulance service a bit more smoother. One of the things that we were talking about is if they could give us like a bit of an estimate, like if they maybe like give us distance estimates. So like if you're doing a 10 kilometers, this is what you pay, because we all know that they are paying. Okay, but it's a bit erratic. I mean, somebody will charge maybe 500 for 2 kilometers. Another person will charge 700 for 2 kilometers. So we really don't know the amount is being charged. You see, there's no paper for that. That's what we are trying to say. If they can tell us exactly how many kilometers and how much should be charged, at least we would know, and we can. And then one of our pediatricians, I think, and a very vibrant pediatric advocate. I'm sure a lot of you know her, Dr. Ya Adoma Odame. I'm sure everybody know Adoma. I mean, one of the things that she brought up was, should we kind of bill everybody that comes to the OPD, like maybe small amount, like everybody pays 2 cedis or like 2 cedis, and then we collect it for some time, and nobody touches this money we are taking. We just say it's ambulance levy, so that whenever we have a critical care baby that needs to be transported by ambulance, we will use this money for that. I'm just saying that it's a bit, the national ambulance, we need their help, and we need, we know they are charging, but it's a bit erratic. I'm not here to tell you how much you should charge for what kilometers the ambulance should move, because you have fuel challenges. We are just saying that if some of you are on the platform, we are just saying that we would like to have like specific rates for specific kilometers so that we can plan ourselves. And then I'll say that as healthcare personnel, I know it's not easy. Yes, I sit in the tertiary hospital, so I hardly do a referral. But I know that let's also I'm giving an example of what Dr. Yadoma of Hope Exchange. Everybody knows Yadoma. If you're in pediatric society, you know Yadoma. I mean, she said that can the hospital contribute, or your health facility maybe give some small money, and then also we low-key bill, everybody that comes to OPD, because we are all family. You never know. I'm not saying we are all trying to prevent birth asphyxia, but you never know when it will happen to you or to your relative or to somebody, your friend or something. So we are helping each other. If it can be done in your facility where we can get some amount of money that can be put aside, and then we say that, yes, we all know the ambulance charges. So this money that we have collected, or maybe our internally generated funds, we take it and then we use it for ambulance services, okay? And then maybe not all of it, maybe a part of it is dedicated for ambulance services, so that even if we have 2/3, and maybe the parents will also bring 1/3, at least we can make a bit of a headway. But I'm just saying that it's still a gray area, and much needs to be improved in terms of ambulance services. Thank you very much. And that also causes one of the major delays and brings about increased mortality and morbidity when it comes to children who have suffered birth asphyxia. Thank you very much.
Thank you so much, Doctor. That was an interesting feedback. I know when it comes to this cost of ambulance, most of us are very, very passionate about it. Someone wants to find out, Madam Adelaide, she says, can the cost of ambulance be borne by the NHIS? Can NHIS absorb this cost, especially when it comes to the newborn? Dr. Washiado.
Yeah, I'm not very sure about that, because I don't really know so much about the things that the NHIS can take on. But I would just say that the NHIS have done a very fantastic job in absorbing some of the things that initially they were not doing. An example is, you know how initially, I would say that a bit of the adult cancers, and maybe the common ones, were being borne by NHIS, and then some of the childhood cancers were not on the NHIS. But by advocacy and then having a bit of meetings here and there, and then talking to them, and they seeing the importance of all these things. Now, more childhood cancers, if not all, I would say that it's being, well, not everything, but majority, some of them is being catered by NHIS, at least a portion of it, if not all of it. But I would just say that, so that would take a bit of advocacy. So yes, Pediatric Society, we can talk to NHIS. We can start brainstorming how can we help, so that maybe part of it, if initially not everything, maybe part of it, how can we help so that they can bear the cost of what should I say, the cost of transporting ill babies across health facilities. I know that it's not an easy question, but as you said, as we have already talked about it, there's always the talking, the brainstorming, and then the possibility and thinking of the possible ways of doing it. Because at the end of the day, the NHIS is there to help Ghanaians, so that health delivery will be much better, much easier, much faster, and everything. And then transporting you so that you get that the needed attention that you need for both baby and mother is one of the core mandates of the NHIS. So I think that we can start some advocacy and then start some brainstorming and talk to them. Maybe Pediatric Society, we are all part of it. So we can have the conversations and see how best NHIS can help us. I wish that they were here so that they can be part of this. They can help us in terms of health financing for referrals, because we know that I mean, in the Ghana policy, standard policy for outcomes, for neonatal outcomes, one of the major standard is referrals. It's referrals, and then the referrals must be fast, must be safe, and must be quick as possible. Of course, you need to stabilize the child before referral, but it's one of the standards, the Ghana standards that we have adopted, and it's actually policy. It's Ghana policy. It's a Ghanaian policy. You understand that we are trying that we will reach certain standards that WHO has given to us, and we have to reach those standards in 2030. We're already in 2024, and if this one of the standards is referrals, I'm sure the NHIS would want to help us, and then we can brainstorm and see how best. I mean, I don't know whether they will start with partial, and later we can see how best they can help us, so that, as I said, it's all health facility and financing, so that even if NHIS, that's 1/3, the parents do 1/3, and then maybe the facility also does 1/3. That's a way forward. So I'm sure that we should start the conversation, and I'm sure we can gain some ground, so that referrals will not be a big stumbling block for the treatment of these vulnerable neonates. Thank you very much.
Thank you so much, Doctor. That is a very insightful feedback. I would like to add something little. Probably internally, for each facility, we could look at ways and means of developing our own referral protocols, and then put measures in place to curtail some of these unfortunate circumstances that are beyond us. Like an idea you said, Dr. Adoma put across, of each person contributing something. If a lower facility could also adapt it and then modify it to suit their situation, where the community pays something little to contribute towards the transfer of this patient, at least until the national level picks it up, and then NHIS or any other stakeholder get involved to help us solve this situation. It will be something little we could do to help the newborn. Thank you so much. Dr. Benedicta. So, Dr. Entry. Hello.
Hello.
Hello. Yes, Doc.
Can I be heard? Yes.
Yes, you can be heard. We've come back to you. We'd like to know, what are some of the immediate complications that a newborn might suffer if they become asphyxiated?
Okay, thank you for the question. So, somehow I think this has been said over and over, that immediately the baby is born, because oxygen is not reaching the baby's brain, there can be problems first off with the baby's breathing. So this baby who is not breathing well because not enough oxygen has entered into the lungs, entered into the brain. Remember, in the brain, we have a portion of the brain that is responsible, we call it the respiratory center, responsible for causing you to breathe. So that is a very critical point, that if this baby is not helped to breathe, obviously we know that once you're not breathing on your own, then your chances of survival are very slim. So that is one of the key issues that happens once the baby is born with asphyxia. Then also, like I said, imagine it being kind of like having, imagine the brain being some kind of computer, and then you have cords that are connected to this computer and electricity running through. Those cords are your blood vessels, electricity is your oxygen. So once you cut off that source or that supply, that computer or that brain is not able to function. That when that happens, that baby can have convulsions. So in the immediate post-asphyxiated period, that child can have convulsions. And then that means that you need to stop these convulsions, because ongoing convulsions further worsen the brain's ability to get oxygen into it and to function properly. So immediately that baby is born, 1, problem to breathing, 2, baby can have convulsions, 3, babies blood glucose can be very low. So you need to check the sugars and then correct it appropriately. In terms of after you've done all of these things, there are other things that can also happen. So that you're also making sure that how much urine is coming out of this baby, because you said that oxygen supply to the kidneys is also a problem. So if this baby is not getting enough oxygen to the kidneys, and let's say you set up your full maintenance IV fluid, that is all the fluid the baby needs in the day, you are running all of these in, and these kidneys have had a problem, then you are going to overwhelm the kidneys. And that too is going to be an immediate problem that you can have. That kidney can be affected. And remember, we mentioned a list of, let me say, causes of birth asphyxia, and infection was one of them. So in that immediate period too, that baby being at risk of infection or already having been exposed to some kind of infectious agent, that is one of the things. Sepsis is also one of the immediate complications the baby can have that also have to be taken care of with the appropriate antibiotics. So really, let me say in a nutshell, these are some of the immediate complications that can occur with the asphyxiated baby. Thank you.
Okay, Doc, thank you so much. Based on this submission, one of our participants is interested in knowing that if we are referring a baby to the next stage and then there are some delays, looking at these complications you've mentioned, what can we do at the lower level to ensure that the child has the needed services before they are transported out?
Thank you very much. So I always say that if you are a facility who is doing deliveries, we must be a bit equipped when it comes to what we are going to do in the case of a problem once that baby is out, which means that it's not only okay to be ready with your syntocinon for contractions and your device to listen to fetal heart rate and everything. You should also prepare for the outcome, which is really why this woman has been, has undergone everything for the past 9 months. So oxygen, we must remember, is a drug. And for babies who are asphyxiated, we are saying they do not have enough. So at your facility, at least you should have a source of oxygen. These are some of the immediate things the baby will need. If you are blessed to have a pulse oximeter, which is a small device that is able to check the amount of oxygen in the baby's blood, that is also great. Then something as basic as a glucometer that will enable you to check the baby's sugar is also important. Then the basic things like an ambu bag, please let me say a functional ambu bag. Quite a number of times you go to places and yes, they have an ambu bag, but it's sitting in the corner somewhere with some dust over it. The bag is very inflated, looking very sad. Every morning, if you're a facility that is undergoing deliveries, please ensure that all these things we are talking about, they are all functional, which means they are checked on a daily basis. You don't go searching when the emergency happens. You have to stay ready for that emergency. So these are the basic things that you should do. Make sure you have your oxygen. Make sure you have an ambu bag. Remember, I said one of the key things is you have to breathe for baby. A functional ambu bag. Make sure that you have, if you can get your glucometer to check your sugars, if you can get your pulse oximeter, that is fine. But if not, you should be breathing for the baby. And then also, certainly, I mean, these are all basic things. If you have the emergency drugs, depending on the level you are, that's also helpful. So say your baby is having seizures, if you have some anticonvulsants, that would be great. Basic antibiotics. Remember, this is neonatal period. The infectious agents are usually the germs in mother's let me say her vagina, we would say female genital tract. So your basic ampicillin, your basic gentamicin, if you give even that, that in itself basic is fair. When the baby is referred to the next point of call, then we would take up, sometimes we have to make sure the doses of, I mentioned one drug, gentamicin, is adequate because baby's kidneys may be affected, but all those to be sorted out. So these are some of the basic things that you can do. And then also it's helpful, I always say that, and depending on your level, if you have any contact, and now we are trying to broaden, Pediatric Society of Ghana, I mean, we cannot tout its role enough. If you have any contact or if you're on the platform, if you have a challenge, please feel free to contact somebody. I have a baby like this. I know the Kibeli platform too is available when it comes to Ghana Health Service facilities. Then you can put it on. This is the baby, this is that. And then we can give you adequate basic information to help you out before you now send the baby on to the next level. Thank you.
Thank you so much, Doctor. Thank you so much for your input. Dr. Sally, please, are you online?
I am.
Yes, Doc. Please, we've looked at the immediate complications, but what about the long term? The baby has survived the neonatal period, has survived the first year of life. Subsequently, what are some complications that a mother or a family can expect to see in their child, and what services are available to the family?
Okay, yeah, thank you very much. So I think Dr. Inchi talked about the immediate complications. Sometimes what we forget as health workers is to actually counsel parents about the possible long-term complications so that parents know exactly what to expect as they take the baby home. Because most of the time when we relent on that, what happens is that once these babies or these mothers experience these challenges in their babies, then they tend to start calling the baby in sober, and then some go and leave the baby somewhere. So I think it's very important that we're actually highlighting this. And one of the things that we must always do is that you have to do a pre-discharge counseling. So after you've managed the baby, before you send that baby home, you must have a sit down with the parents where you explain some of these things, these things that may actually happen to them. So one of the first things that can occur, we say they may have varying degrees of, let's say, learning disability or intellectual disability, where you find that depending on the severity of asphyxia, you find that they may not be functioning at par with their colleagues in terms of even doing activities of daily living or in terms of education. So that's one of the things that you have to tell them. And then you would hammer on them based on the severity of asphyxia. Well, you never really know for certain, but depending on the severity, you can tell the parents that, okay, your baby has this condition, and some of the challenges we know that can occur, that as your baby grows, you may find that, okay, they may not be functioning at par intellectually with other babies who did not go through this challenge. So varying degrees of intellectual learning disability, that's one. And I think the most common one that a lot of us know is the cerebral palsy, which is like a movement disorder where you find that you have to let the mother know, okay, we know that at this age, your baby, a well baby or a baby who hasn't gone through these challenges would be able to achieve neck control, be able to sit, will be able to walk. But because of these challenges, it's likely that your baby may actually have challenges in this regard. So if you find that maybe your baby is 1 year, 1.5, and is still not walking, don't think that is because somebody has looked at your baby with some bad eyes, but it's actually as a result of this birth asphyxia. So learning disability, varying degrees of cerebral palsy, and then some of it comes with challenges when it comes to feeding, etc. So you have to also mention that. And then hearing and visual abnormalities. Yes, some can actually go blind depending on which part of the brain is affected. Some can actually have challenges with hearing. And then seizure disorder, what we call epilepsy. So at least if you are discharging a baby and you don't say anything at all to these parents, one of the things that you have to say is that your baby may have challenges with learning, your baby may have challenges with movement, your baby may have challenges with hearing and then vision, and then your baby may develop seizures. Now, if you happen to find any of these, you have to make sure that don't be surprised. Don't blame yourself. Don't say it's because you're giving birth to a baby of the gods or a baby of a river or something. So you empower them, and then you also encourage them to come for follow-up, because like a baby who you've managed from moderate to severe HIV, for instance, you would want to, these are babies that we say would need high-risk follow-up, where you're actually screening them so that you can find if they have visual abnormalities, you pick them up early, and then a lot of the time you're able to intervene. So if you don't know at all, at least these 5 things you must say to every parent who's had a child who has moderate to severe HIV, and then you encourage them to follow up. And then when you follow up, make sure it's focused enough, make sure you screen them for all these problems. And then once you find them, say if you have a patient who you think is developing or has developed cerebral palsy, you know that you have to refer them to see the physical therapist or the occupational therapist. If they're having eye problems, the ophthalmologist will come in. If they're having hearing problems, the audiologist will come in, and so on and so forth. Yes, so speech and language therapy. So the facilities are there. It's just about coordinating the care, following up, making the parents understand that these can happen. And once they happen and they come to you, knowing where to channel these babies to so that they get the needed help. And then all together, they don't become so compromised, and then they're able to, at least you get them to the point where they're able to maybe achieve some activities of daily living or integrate a little better. Because sometimes when it comes to all these movement issues, if you start intervention early, you'll find that these babies tend to do much better than when you leave them, then they develop contractions, etc., etc. So yes, if nothing at all, these 5 things you must mention to them: learning disability, cerebral palsy, hearing and visual abnormalities, and the possibility of developing epilepsy. Yeah, thank you.
Thank you so much, Doctor. Thank you so much for letting us know the long-term complications of that asphyxia on the child. We have some concerns raised in the audience. One audience brought up the fact that apart from ambulance fare and financial problems of parents, referring asphyxiated babies to the referral tertiary facility has been a big issue, because sometimes the receiving facility thinks they are not going to do anything different from the care you are giving. Hence, they delay in receiving the baby, and sometimes this leads to worsening of the baby's condition. Dr. Boachi Adam, I don't know if you may have some comments about this concern raised by one of our participants.
Sure, and it's a thank you, Sheena. It's a very good concern, and one that needs to be looked at. I would say that from my experience, space, I would say, is limited. Like, I am in a facility. I'm in Cath. I'm in Cath. So we have the number of cots that we can take, and then our NICU can take six babies at a time. Our intermediate, so that's like a bit of like a high dependency ward, can take maybe like 14. And then if we adjust and everything, we can do like 15. So sometimes the reality is that our own labor wards have given us a bit of, we ourselves have asphyxiated babies. We have other critically ill babies that are with us. And then if you are in Ashanti region, and then maybe Brown Hartford region, no, we don't have Brown Hartford region anymore, Bono, Ahafo region, and a bit of Western, you can see that the only place you have, and then Savannah region, Savannah, and then Upper East, Upper West, you can see that the only place that have a very strong pediatric surgery team is the CAS group. I know that the other places in Greater Accra, they have multiple hospitals that have pediatric surgery group. But the places I have mentioned is the Konfanochi Pediatric Surgery Group. They are the strongest in that part of the regions that I've mentioned. So you see all these babies who are coming to us. So sometimes I know that it looks as if, because the person said tertiary hospital, so I'm using my hospital. So sometimes it looks as if we do not want to take your baby, but it's not that. It's like we don't have the space for your baby. Do you understand? We do not have the space for your baby. And then also sometimes when they tell us the state of the baby, and then you are, I don't want to mention names before somebody will say that I'm using their hospital, I'm targeting their hospital in a public forum. So maybe if you are very far off, and then you tell me that, oh, you have this baby, you have resuscitated for maybe 3 hours, and the baby is still not breathing, then the heart rate is like it's like 40, SpO2 is like 20%, and you are doing CPR for this baby. And I look at where you are coming from, and then you are now going to get national ambulance to bring this baby. Then from my experience, the babies come in almost BID. The babies come in almost BID. And sometimes what you are telling us is not a baby in a very good state. And the prognosis is very poor. I'm not saying that because of that we won't take the baby, but maybe we will tell you some things to do at your facility, if you can do them, to much stabilize the baby and give the baby a chance before you refer the baby to us. Remember, the referral, moving a baby in a referral also brings a certain risk on a baby. That is not a good thing. So unless you stabilize the baby, you cannot move the baby. So I'm just saying that sometimes there is want of space, because we do not, I mean, talking from my hospital, because I'm in a tertiary hospital, there is no eternal space that there is always space all the time. So sometimes there is no space. Sometimes there's no place, even pot of oxygen that we can give to this child. There is no CPAP machine we can put this child on. And there is no ventilatory support we can give to this child. You understand? Good. And then sometimes the condition in which you are bringing the child, a child who has not, you have been resuscitated from birth, has no breathing, there's no activity, heart rate is low, you've given your adrenaline, it's not working, or you may be, because you're in a place you can't even give adrenaline. Okay, you're doing CPR, you say you've done it for 3 hours, okay, or maybe 4 hours. The last time somebody said they've been doing CPR for 8 hours, okay. I didn't admit the child, but one of my specialists admitted the child. The child came from very far. And then when they brought the child had died. And the parents had to pay. Once the child comes to us BID, automatically it becomes a coroner. It is going to court. Then we cannot give the body back to the parents. So that is a problem. Because even though, yes, you brought the child, but once we accept the child, and we say the child is dead, or we do maybe a bit of resuscitation and the child doesn't make it, it becomes a coroner. It becomes all complex. So sometimes I think maybe a bit of a misunderstanding, but we all have our heart to save babies. We all have the heart to save babies. So I would say that, yes, maybe it may be seeming like they may not be wanting to take their child, but they may give you a good reason. But you see, they may give you a good reason. So I think we should understand each other. If there's a misunderstanding, we should maybe talk openly. That's why we have I know that in Ashanti region, we have a platform where sometimes emotions get overboard and everything. But at other times too, we talk openly, and then even other people will be finding, I know that other people will be finding places for babies who are being referred, okay? So I think that if you feel, if a person is saying that, oh, this is a problem, correct this, correct that, correct this, don't think that, oh, the person doesn't want to take the baby. I mean, if the baby is stable and the baby can come over, why not? We want to save the child. But I mean, a baby have been resuscitated, and the SpO2 is 10%. I'm just giving an example. And you are 2-3 hours from the tertiary hospital, and you say that an ambulance should come for this baby with 10% and bring to the tertiary hospital. I am not God, but from what I have seen, by the time this child reaches the tertiary hospital, this child will be almost gone, or will probably be dead. Okay. So sometimes even what we will tell you may even stabilize the child, and then later the child may come in a better referral shape. So I just want you to know that we, at least those in the tertiary hospital, I'm sure I speak for everybody, we are pediatricians. We all have a mandate to save babies. And if we are given the vibe that we don't want to take your baby, it's not the vibe that we want to give. There is a misunderstanding. And I'm sure that it's a case-to-case basis. And every time you are getting that vibe, you can maybe voice it out, and then you can have a discussion with the person on the other side, okay?
the person on the other side. And I'm sure, as you have said, join platforms so that you can even put your concerns on those platforms, wherever you find yourself. I'm sure the neonatal platform, because it is also becoming like a national policy. Because the platform I'm on, I'm in a tertiary hospital. I am not Ghana Health Service, but it's a Ghana Health Service platform. And then because we are all neonatal group, and we are all taking care of neonates, everybody's on it. The tertiary hospitals on it, the CHAG is on it, some of the private hospitals are all on it, because our aim is the same. We want to help save more neonates. So if there's a problem like that, you can also gently put it on the page, and I'm sure a solution will be found. But honestly, I'm sure whatever situation you find yourself, if that's the vibe you are getting, maybe talk to the person more, and then I'm sure the person will explain some of these things. Because it is very sad to have a baby. I mean, Confanoche, if you bring us a BID, I'm telling you, we don't give the babies back to their parents. It automatically becomes a coroner's case. Now it needs to go to court if the parents want to bury that child. Okay. So we need to stabilize that child. Or sometimes we just say that we tell you, we look at what you have done, we look at the history, we look at everything, and then we look at the transport. We just say, this is looking like a very poor prognosis. And we don't even think the child might even survive the transport, which is a legitimate observation. Okay. Sometimes I know that we want to save every baby, and that you've been resuscitating this child for a couple of hours, and your heart is, I want to save this baby. But unfortunately for us, sometimes the asphyxia is severe, and where you are, and then maybe where help can be gotten, how the child is looking, even if you do the referral, we can't do much for the child, okay? And sometimes we can do something for the child if we intervene early. That's why I'm saying that it is a case-by-case situation, and that needs to be discussed, okay? So I'm sorry you got that vibe from any tertiary hospital, but as I said, that is not the aim of tertiary hospitals at all. I mean, I don't think that we don't want to take cases at all. Thank you very much.
Thank you so much, Doctor.
Can I just add something small too?
Yes, please, you can.
Just to agree with what my colleague has said, and that sometimes when the babies are so compromised and you know that this baby is not likely going to survive transit or transport to the hospital, that may be a reason why something like that may be said. But that said, for some of the babies, I think like mild to moderate, whilst you are trying to, maybe parents are trying to raise money to get an ambulance, or you're trying to, set up. I think one of the things we must begin to normalize is actually taking advice from the hospital you want to refer the baby to. So you have a baby who may be mildly encephalopathic or moderately, and this baby is breathing in room, maybe saturations are not good. You can call in, like I think Dr. Inchi actually said this. You call in and then we say, okay, so what's the saturation? Okay, increase maybe your flow rate to that. Okay, is the baby having seizures? Okay, yes. Okay, this is what I'm seeing. Okay, give this baby 20 milligram per kg of Phenobab. How much fluid are you giving? Okay, maybe I've started 50%. We say, no, stop 50%. Put the baby on 10%. Do this maybe 40 mil per kg. So we can actually give you advice whilst waiting, and that can also make a difference. So let's not just say, okay, we have a baby who has asphyxia and we are calling, and or we've called, an ambulance is now coming, and so you don't know. I think we must begin to normalize actually getting pre-transfer advice from wherever you intend to refer the baby to, so they can actually give you advice. So by the time the baby comes in, sugars are fine, baby's on the correct IV fluid, baby's maybe has had some seizures, it's been corrected, it's been aborted, etc. So I think that in addition to that, we must begin to normalize. If you can get through to the referral unit, you must at least let's normalize giving the pre-transfer advice whilst waiting for all these other processes to settle, and that can actually impact on the way the patient even gets to us at the facility. Yeah, thank you.
Thank you so much, Doctor. Thank you for the feedback. Please, the forum is open for contribution from the audience. If anyone has a question or contributions, please put it across. You could raise your hand to add in your voice to the discussion as we are ongoing. Dr. Sally, please, I have another question for you. Sometimes you find relatives coming in with herbal treatment. They tell you they have some concoctions in town that has been known to help the newborns when they are sick. Some targets as Astramedru and all that. I want to know, is it possible to combine orthodox treatment with traditional medicine treatment?
I think the answer to that would be an emphatic no.
Okay.
We communicate with parents. You see, if relatives come in and they say, okay, we brought this medication from home, blah blah blah, we want you to give it maybe orally, etc. You have to tell them that, okay, this is a hospital, and that, okay, you're not trained to do that. You don't know, like, you're not certified to give herbal medications to a baby who's maybe asphyxiated or has any other condition. So I think it's just about communication. If the baby gets home and you know that so you don't, the answer is no. You don't have a certificate. You are not you don't have the authority. You don't know anything about whatever they are bringing. Once the baby is in hospital, you have to let them know nicely that unfortunately it's not within your power to administer those medications, because once you have admitted the baby in your unit, you owe a duty of care to the patient, and you have to make sure that whatever you are giving you are doing it within your knowledge as a physician. So if somebody brings you something that herbal medications they give, you must decline nicely. But then you have to reassure them that with the knowledge that you've acquired as a doctor, these are some of the things that work, and that you are doing everything within your power to see if to give baby a fair chance. But you really are unable, you are sorry, and that you are unable to administer those medications. And then sometimes you go ahead and say, okay, so maybe this herbal medication that you are coming to give to the baby may have something that may help. But what happens is that it's not very refined. It's not refined at all. So it contains maybe a million other things that may actually, not help the baby. So you kind of just plead with them that, okay, once the baby is in hospital, they should allow you to do what is within your power, or that what is within your knowledge, and that unfortunately you are unable to, administer those medications. Sometimes I even go ahead and say, oh, they'll take my license, I have kids to feed, and it becomes like a laughing matter to some extent. But you would have to decline nicely, but you have to be respectful about it whilst you go about it. Yeah, but the answer is no.
Okay, doctor, thank you so much. Dr. Jacqueline, please, I see your hand up. Dr. Joycelyn, sorry. Hello, Doc. Dr. Joycelyn.
Hello? Hello, please, can you hear me?
Yes, I can hear you.
Good evening. Thank you so much for the opportunity. I have really enjoyed the discussions. I just wanted us being such a great platform to look at certain other things. So one thing I see that can help is right from antenatal, mothers that are identified with certain risk factors. I believe it's being done, but I see that there's quite a lot of challenges. Like they need to be identified to deliver at the right place. Like for some of the risk factors that could expose, we know that this child might have problems, risk factors for asphyxia. They need to be referred to the proper facility or level of care to be delivered. I think that will help a lot. I know there are challenges. Some mothers will be referred properly that you need to deliver at a higher level facility because of these risk factors, but then they will end up at a health center or elsewhere. And I think this is a great forum to discuss. I believe if you work towards this, it will help reduce some of the cases. Also, I think there's been a mention about the delays. One challenge I see from where I sit with the district, I am in the eastern region. Most of our district hospitals have just 1 to 2 medical officers just because of the I need to have cesarean session, but you have 1 or 2 medical officers, and definitely can be challenging. If they have other cases, they are not able to attend, and that is also a very challenge. So I think this is one area that maybe Pediatric Society we need to look at, and Ghana Health Service, being a bigger body, can help so that we manage this. I believe are some things that can help. I also want to add to what Dr. Enu said about referrals. We need to work together. I think sometimes those at the health center or district hospital, when they discuss with you certain cases, certain asphyxia cases that have very prognosis, not to refer. It seems like you don't want to take the case, but the scenario that was given, this baby clearly needed not to be referred. It's cost to the family. So I believe that we should all work together. Thank you so much. Over.
Thank you so much, Doctor, for your input.
Okay, so can I add
grateful
on
for that
to?
input.
Can I add on, Sheena? I'll say that
Yes,
I
please, you
agree
can.
with what Dr. Is it Joycelyn Asibe?
Joycelyn,
Joycelyn
yes,
is the one
ma'am.
who spoke, isn't it?
Yeah,
Okay.
Joycelyn, yes.
The one spoke. Okay, so today it's just by the way, today is Jacqueline and Joycelyn's birthday. So happy birthday to you
Wow,
twins.
happy birthday.
Twin pediatricians. We are happy to
Thank
have
you so much. Thank you.
And as I said, it's I mean, if we know that, I mean, I know that where I work, one of the common local names they give to birth asphyxia is astrum. And then of course sometimes they say it's what evil eye, isn't it? And then you asked about herbal preparation. So sometimes you as you said, I mean a colleague answered, and then she said she would not allow them to bring it. She's not a herbalist. Of course, these are legitimate answers. And then sometimes too they have these these white anklets. So
Yeah,
I mean they can bring it.
beads.
Yes, the anklet, they put it on the
Beads, yes.
ankle
On the arms,
beads, and they put it around the knees, and then the hands and everything.
the hands, yeah.
I mean, sometimes they would like to bring it for a severely asphyxiated child because maybe the ashram doctor has done some things to add on to it. I mean, if you are going to put it on the knee of the child, I mean, when I see that, look, they really believe this thing. I mean, this thing is going to be on the knee of the child. And it's not like the child is going to put in the mouth or anything like that. Once it's not a drug, I'm going to put in the mouth. Once it's not a drug, I'm going to smear topically smear on the baby. And it's just maybe just beads. And even the beads, where is it? Is if it's going to be on the knee. Maybe I may ask them to go and wash it and clean it a bit. I mean, I will discuss with the team and see whether we can put it there. Because, there are some traditional things, they are not so harmful, okay? We are not going to smear it. We are not going to put it in the anal region. We are not going to put it in the nose or in the mouth. You're not going to give anything like that. It's just maybe or something, they come with a patch or something. I mean, if it's not, I know that it is not dirty, and then also it doesn't have any active ingredients or in it. It's just something they have prayed spiritually on it. I mean, sometimes just for them to know that, I mean, especially when I see that the prognosis of the child is very poor. I mean, I do that so that they will feel that, look, we've done everything. But of course, as the one facilitator said, if it is something they are going to drink, something they are going to smear on the body, something we are going to inhale and all of that, that one is a big no. It's a big no. And then I like the fact that someone talked about the fact that we should, if you're a referring facility, we should, before you even bring the baby and everything, we should normalize you taking a bit of talking together and then maybe taking what can be done for the child to stabilize the child before the child is brought to another referring facility. And then the very fact that, I know Joycelyn said it, but there are some cases that when you tell us, I'm using Confanochi as a place. Confanochi, we have 3 fellows. Sometimes we discuss the case, we are like, no, the prognosis, I mean, not 3 just fellows, 3 neonatologists. I would just say that we would just say that this case we are discussing, the prognosis is poor. And we have to give you that feedback. I mean, it's not a very nice feedback, but we just look at the circumstances and then we are like, we don't really think we can do very much for this child, even if this child comes to our end. Of course, sometimes we can do something, but there are sometimes we just can't do much. Even if we tell you what you should do, there are sometimes there's not much. The child has been really, really, really bad, and it's not going to be really good. I mean, the end is not going to be good if we say even do this, do that, and bring the child to us. We have to normalize that. And then, so if we intervene early, and then we call early, I am very sure minority of such children will fall under what I'm talking about. But it's a reality that pediatricians face at various referral centers. And the earlier the intervention, the minority of babies will fall under that's poor prognosis that we all don't want to hear. Thank you very much.
Thank you so much, Dr. Boachiado. One of our participants wants to know that what is the ideal duration for resuscitating a baby? If a baby is asphyxiated, you are doing the bag and mask, how long is the ideal time that this resuscitation should be ongoing until the team says that, okay, at this stage, we may have to put a stop to the resuscitation? Dr. Boachiado.
Okay, it's coming to me. You know that in our lower facilities, so our primary health centers, our CHIP compounds, we have been sharing, we have been training them with helping babies breathe. And then our district hospitals, and then, of course, our regional hospitals and our tertiary hospitals, we have been training with a neonatal resuscitation program. Okay, so I mean, it depends on where you are. Okay, it depends on because helping babies breathe focuses on just the ventilation, isn't it? Just the ventilation, and then ventilating the child to a place where they can add the cardiac compression to it. Okay, I'm sure when they add the cardiac compression, they can add adrenaline and all the other things. Okay, I mean, from literature, it's been shown that if you do resuscitation for 20 minutes, 20 to 30 minutes maximum, and there is no sign of life. No sign of life means that you cannot, there's no heartbeat, and then there is no breathing. Then, I mean, if you've done it for, actually the time I think is 20 minutes. Okay, maybe some people will prolong it to 30 minutes to be sure. Then it's not likely. It's not likely that this child is going to come back. If you've done resuscitation and for 20 to 30 minutes, there's no heart rate, and then there is no the technical word they use is that there's no sign of life. So if there's no sign of life means that there's no heart rate, and then there is no breathing. Okay, then the baby is pronounced not being alive. Okay, but we know that it differs if you are in a regional hospital and then you are in a tertiary hospital, because now we are, even if you're in a tertiary hospital, I know there are residents on the call. That's why I'm going to this level with you, residents. Now we are not just saying that the pulse oximeter and then the the stethoscope is the only way that you can check for a sign of heart, the sign of the heart being there. Now we are saying that put on ECG probes, because maybe your ears are not hearing the heartbeat, but the heartbeat is there. Okay, so depending on where you are, its signs of life may be different. Because obviously, if you're a health center, there's no heart, you have a stethoscope, there's no heart rate, there's no heart rate, the child is not breathing, you've done resuscitation for 20 minutes to 30 minutes, the child is not there. I would not say bring it to the district hospital. You are in the district hospital, you've done it for 20 to 30 minutes, there's no heart rate, there's no respiratory rate. And then, of course, if you're a doctor, you check for other things like the five brainstem reflexes. Okay, so you look out for the 5 brainstem reflexes. I'm talking to doctors here. Okay, so you know what you are looking out for. You make sure your cornea reflex, your pain reflex, and all the other things, your doll's eye movement, all of this, your cough reflex. And then if you're in a tertiary hospital, I'm sure this baby might have been intubated. And then so you check for the cough reflex, and then maybe the gag. Okay, you add it, you make sure that your 5 at least reflexes have been done by 2 people, and you are very sure nothing is showing. Okay, but if you are in a regional and tertiary hospital, I would say that put on your probes. Okay, put on your probes. But if you say using the stethoscope alone, you didn't hear, but you're at a higher facility. You're at a higher facility, and that if you have the probes, because not all regional hospitals have the ECG probes. If you have the TT, you cannot hear, you've done your resuscitation for 20 to 30 minutes, you cannot hear with your stethoscope, you cannot hear the heart rate, you've given your adrenaline 3 times, you cannot hear with your heart, to make sure that if you're regional and tertiary, you can be sure and say this baby is gone. I would, after the 3 adrenaline, I will check for the brainstem reflexes, 5 of them, and then tertiary people, and then regional people, because I know that now regional, all our pediatricians are there, and now we are even training neonatologists, and they're all going to go to regional hospitals, and maybe some of you go to what is it called, district hospitals. So you just make sure that these are done, your reflexes, check your reflexes, and then also if you have your ECG probes, you have put it there, because those are the new guidelines the military resuscitation program has brought. But if you are at the CHIPS compound, district hospital, you are alone, I would just say use your stethoscope, and then use your respiratory rate not there. And then if you're a doctor and you have been taught all these reflexes, I mean, to add it to be sure, you can do that. But if there are no signs of life, you've done your resuscitation, there are no sign of life, 20 minutes, okay, the literature says 20 minutes, but of course, if you want to, I always teach my fellows in training, and then my residents, that add another 10 minutes, okay? But if there's a sign of life, that means that the heart rate is there, you must you have to follow the program. The program is there. We are not talking about that here. Follow the program and go according to the algorithm, what you should do. Okay. I think I've made it more complex. Sheena,
can I say something? Yes, I think Ajwa has done very. This is actually, I think Ajwa has done very. It's actually a very difficult question to answer, based on where we find ourselves. Where if a baby comes out compromised, you're now looking for ambu bag. It takes you like 2 minutes to find the ambu bag. Then you find the ambu bag, you can't get a well-fitting face mask, and then now somebody's pulling oxygen from somewhere. So it's actually very difficult. In a good place, I think those 20 minutes is in a good place where there's skilled attendants at delivery, baby comes out, initial steps, PPV, within sometimes by 5 minutes the baby is intubated, ECG probes attached, or etc. etc. So then within that 20 minutes, your adrenaline is gone in, your boluses have gone in, then you know that okay, I have done enough, and then maybe look at the pupils and all that. But in our setting, a lot of other factors come into play. How adequately is this baby being resuscitated? Sometimes you go in and they say we've been resuscitating for a while, and you realize that the chest compression cry is not, it's not working well. So you come in and the baby's been they've resuscitated for like 30 minutes. You come out, you put on oxygen, maybe it's still being resuscitated in room air. You put on oxygen, you do all that, and then baby starts to breathe and all that. So yeah, it's actually a very difficult question to answer. But I think we have to give some leeway based on where we practice, because things are not very ideal. And then, yes, like she said, sometimes one of the ways you may be able to tell to stop is if you do your brainstem reflexes and then you find that, okay, the baby's actually gone. But yeah, at least those in the district, then that what it means is that let's make sure we learn how to resuscitate very well. And then we know that we are doing that chest compression. We've done everything that we need to do, and then the baby's not responding. But if somebody is doing chest compression, then you can see that it's not compressing the chest at all. You can see that maybe they've been bagging in room air, then the adequacy of resuscitation also comes into play. Yeah, just to add that, so that we have to look at it from where we practice as well.
Okay, Doctor, thank you so much for the input. Dr. Benedicta, please, are you with us?
Sheena, I want to say something. You know that so it all comes to preparation. I know that we've all done the HBB training and everything, and I'm talking about primary, our primary health care and everything. And when you have a baby and you're resuscitating, do not think of oxygen per se. Do you understand? The research has shown starting resuscitation with room air, it saves time and the outcomes are better. All of getting your basic things that we want on the resuscitation table is your ambu bag, your different sizes of face mask, and always start with room air. The literature has shown and the research is there. People who started looking for oxygen to resuscitate newborns who needed resuscitation, and those who started with room air, those who started with room air did much better and they have greater outcomes. So from the European Association, when a baby needs resuscitation, they recommend that you start with room air. And then later on, maybe if it's still not getting on, whilst you are resuscitating with room air, somebody can get oxygen. Do not say that we are going to look for oxygen to come and connect to this ambu bag before we resuscitate this child, because that is a wasting of time. So I want it to go all out, like we teach in HBB, and even in the neonatal resuscitation program, the algorithm, we always start with room air. Okay, so I'm saying this so that it will not delay us, so that somebody will be saying that, hey, I'm going to look for oxygen to attach to the ambu bag. Start with room air, and then if you have another hand, the person can connect the oxygen to it. But do not wait until you connect oxygen before you start the resuscitation. That's just all I wanted to add in. Okay, thank you very much.
Okay, Doc. Okay, Doc. Thank you so much.
Sheena, one last one. I think, ma'am, almost out of battery. Yeah. So I don't know whether it's actually in response to what I said, but I was trying to create a point that sometimes you come in and somebody's been going at it for like 20 minutes and the baby is being bagged in room A. Certainly you start in room A, but if the baby is not responding, you have to connect to oxygen. Down to the timing. I said, I think I got a call. I wasn't saying we should look for oxygen to, bag, but certainly you start. But if the baby is not responding, let's also not lose sight of the fact that some people go, and I've had personal experiences where the adrenaline is all over. So you find that they've been going at it 20, 30 minutes and they are calling you, and then you come and you realize that the baby's not, they're even bagging with 21%. But certainly you start in room A, and that's something that is standard. If the baby is not responding, then you have to make sure that you add oxygen to it. I think maybe there have been I may not have come out very clearly, but what I was saying is that if you are not winning, then you have to add that oxygen. Yeah.
Okay, so oxygen is important, but If it's not readily available at the time you receive the baby, you start with room air. And then with time, as you get help, the other person comes in and then they connect the oxygen and then the resuscitation continues. Thank you so much for the input. Please, Dr. Sally, before you go away, we have one question for you. Please, sometimes a baby will be brought to your unit, resuscitated for about 3 hours before coming, with no sign of life, but the pulse oximeter is giving you figures, and there is no other sign of life. How long do you resuscitate such a baby before you give up?
So, I mean, I think you have to actually, like we always say, you treat the patient and not, because machines can malfunction. So if you put a pulse oximeter there, sometimes when you're actually doing, you can have a patient who's brain dead and then the pulse oximeter will be reading one, and then once you realize that, oh, your pupils are fixed and dilated, you have to stop, and then everything quietens down. So I think it still comes back to what we're saying. If there are no signs of life, you've listened in a good place, if you have ECG, you've done your dose, eye reflexes, all those things, and the baby's gone, it's not the reading of the pulse oximeter that would, determine. If you have to, you can call a senior colleague to come in and assess as well. But we always have to remember that machines do malfunction, and that's your clinical assessment trumps a lot of especially pulse oximeters. They are one of the things that you can put it on your finger and then it's giving you all sorts of readings. Sometimes you find that people are not waiting for the tracing to actually be.
Hello? I think we lost Dr. Sally over there. Okay, so I would like to say a very big thank you to all our
especially in a situation like this, you call a senior colleague to also come in and assess. And then if it's not looking like the baby's alive, then likely that's what it is, rather than just the pulse oximeter reading being the determinant of whether the baby's alive or not.
Hello, Dr. Sally. Okay. I think she's made her point clear that sometimes the equipment can malfunction. So if there are no other signs of life to indicate that you need to continue the resuscitation, then you have to call it as it is. You have to stop the resuscitation, because the pulse oximeter may be reading, but it's actually not picking up the signal of the baby. But once you are sure that there is no sign of life, then you may have to call in as it is. So we are most grateful to everybody for making time to be with us today. We've had an open forum discussing at length what beta asphyxia is, and as a nation, the impact beta asphyxia has on us, its contributions to neonatal mortalities. I think for under 5 mortalities, it's taking up about almost 47% of it. So it's a condition that needs our attention. It's a condition that needs further discussion to bring on board all stakeholders. One key thing I realized from our discussion is the fact that our transfer of associated cases to the next level can be sometimes so challenging. And this is a conversation that shouldn't end here. It's something we need to keep talking about until we get a realistic solution. The newborn is so fragile and they are our future. We put in measures today to see their survival. Tomorrow we have great leaders to see us through. So to bring the curtains to a close, I would like our facilitators to give us their final words. And then Dr. Jacqueline will also give us her final words before we close. So Dr. Batiyadom, if you're online, please, if you could give us your final words.
So thank you so much, Pediatric Society of Ghana, and then Dr. Jacqueline and your committee and other facilitators that been here, and of course, Sheena yourself. We want to say that, of course, we've talked about birth asphyxia this month, and as you have to use your own words and then the words of one of my favorite mentors, Professor Jikwa Planju, who is also on the call. Birth asphyxia, we don't want it, because prevention, as you said, is always better than cure. And we have seen that sometimes if we don't prevent it, it can go either way. So at every birth, we must, from the midwife, we had a midwife who spoke very brilliantly on this call. She told us, like, some of the things that can make us pick high risk babies who are at risk of high risk pregnancies at risk of birth asphyxia. So we should learn, we should all learn, and then of course from our side as pediatricians and people who take care of newborns, we should learn at least how to do newborn resuscitation, and then I'm very sure that we can save a lot of babies and for Mother Ghana. Thank you very much.
Thank you so much, Doctor. Thank you so much for your time. Dr. Sally, please, do you have any final words for us?
Yes, Sheena, thank you. Thank you so much. Yeah, just to say that it's been an absolute pleasure to have been part of this discussion. Birth asphyxia is one of my passions. It's always a pleasure to join the discussion. And like was said earlier, we probably are not making a lot of noise about birth asphyxia as compared to what we do for jaundice, etc. So maybe after this presentation or after
Hello? I think we might have lost her. Hello, Dr. Sally. Hello? I think we've lost her. Dr. Benedicta, if you're online, could you give us your final words?
Hello, can I be heard, please?
Yes, please, you can.
Okay, so I think just as the previous speakers have said, the only thing I'll add on to it would be advocacy, advocacy, advocacy. I think a big thank you to PSG, together with Dr. Joycelyn and her team members for this presentation. Advocacy cannot be underestimated. It cannot be, we cannot talk about advocacy enough, because it's through these platforms that we are able to send the message out there, that we are able to let people be aware. Maybe a few things that are maybe highlights at the end is that we are all together in this fight for our newborns, for our neonates. So please do not be in any way hesitant to contact, to reach out, to call, so that, like we've spoken about, we can start some pre-transfer basic resuscitation or give some basic treatment before the baby is sent. And I think someone put it on the platform, I'll highlight it again. In utero transfer, okay, that's of the mother. So if a high-risk mom, I think Dr. Joycelyn also emphasized it, make sure that this mother goes with baby to a center that is well-equipped to help the outcome that this mother has labored 9 whole months for, to help that outcome, that is the baby, have a successful, let me say, newborn period. Thank you.
Thank you. Please, Madam Millicent, are you online? Hello?
Yes, Trina, I'm here.
Okay, please, can you give us your final feedback?
Oh, okay. So I'm very happy to be part of this forum. And I think that my colleague midwives are also doing our best to give a good rate on the ABGA score, so we could be able to identify them early. I think some of them are beyond us, like referring babies to a higher facility And I know that with time we'll get there. So I'm happy to be part of this forum and thank you, everybody. Bye.
Thank you so much, Madam Ellison. Please, Dr. Jacqueline, we would like to hear final remarks from you as our chairperson and our
Thank
host
you
for
so
today.
much. Thank you so much, Sheena and the team. We are very grateful. It's been a great session. What I'm happy is that all the public has gotten their share, and then we, the health workers, has even got more information and more knowledge. I'm really happy about this challenge to Pediatric Society, and I'm very happy Madam Chair is on, Madam Hilda, Dr. Pond, they are all on to do advocacy to get ambulance free, at least for neonates, or even more specifically asphyxiated babies. So I think it's a good challenge. We did it for jaundice and others, and we know we can do this. As we said in pediatrics, we did it for the 4 childhood cancers and it worked. So I believe this is a great challenge. If not for anything, this BAM 2024, this is a great challenge for us. We are very, very grateful for all what we have learned. Very, very grateful to our facilitators. Short notice, but they've really been up to it. Thank you so much. Thank you, Pediatric Society of Ghana. The month is not ending, but it's the BAM activities is ending today, but that is not all. We would want to continue to say the training on neonatal resuscitation to get the skill and keep these babies to breathe. And then we learned a lot from Madam Millicent about good antenatal care, picking high risk so that we don't even get it there. As our great mentor has said of Jekua, we don't want to get the asphyxia baby. So good antenatal care, and then we identify high risk and identify as much. We are very, very grateful for a great month. Let's continue the hard work and then keep every baby breathing. Thank you so much. And Madam Chair is on. I don't know if you want to add more, Dr. Pong, if you want to add anything on the neck, if anybody wants to add anything. But BR, we are very grateful for the opportunity to lead this advocacy month. Let's all keep up the hard work and keep our babies all breathing. Thank you. Over, Madam Sheila.
Thank you, Dr. Jacqueline. Please, Madam President, our NEC executives, if you are on call, if you could, do you have any feedback, any comments, contributions?
Okay, then I think, Sheena, we can go on and we can close. Yes, thank you.
So we thank everybody for making time to join us today. We are most grateful. My chair has said it, so Dr. Jacqueline, we are grateful to you for this opportunity, Pediatric Society, all our audience. Thank you so much for your time. Have a good evening.
Sorry, I couldn't unmute, but all I'll say is that on behalf of the President and NEC, we are grateful to all of you for joining to BAR. And a lot has been said and discussed, and we have taken notes of some of the challenges and concerns that have been raised. Let's all advocate together, and we'll create the opportunity for everyone to take part in this advocacy till we see what we want to see when it comes to newborn care, even beyond birth asphyxia. So thank you all for joining. Good evening. And
Thank
over.
you.
This is Dr. Opon, Vice President.
Oh, okay. Nice to meet you, Doc. Thank you to everybody once again, and have a very good evening.
Thank you. Bye-bye, everybody. Thank
Bye.
you. Bye-bye.
Bye.